Good evening, everyone. I'm Pooja Gohil from the medical team of Cipla Limited, and it is my pleasure to welcome you all to this engaging live wire webinar on best practices in prophylaxis and management of endophthalmitis. It is a pleasure to have such eminent faculty with us today for this webinar. I would like to warmly welcome our chairperson and moderator for tonight, Dr. Lalit Verma sir, who needs no introduction, but to list a few, he is the president of AIS and Director of Vitreoretina Services at Center for Sight, New Delhi. And he's an invited speaker in more than 600 conferences and workshops and has delivered hundreds of presentations in national as well as international conferences. He has more than 170 publications and has been a part of numerous research projects and has many chapters published in national as well as international books and has more than 50 awards to his merit. We welcome you, sir. And not taking much of your time, I would like to hand over the session to you to take the meeting forward and introduce the speakers. Over to you, sir.
Thank you, Pooja, for this not so needed introduction, because I think we should talk more science rather than talking about each other. Uh, I welcome you all on this very important webinar, although a lot of repeated talks have happened on this topic. But this topic I think it needs repeated hammering, primarily because it's such an important topic and encompasses can affect virtually any practice. And we'll be talking on both prophylaxis as well as management, as well as very important things, in a hospital, how to, prevent. And then Dr. Chandrasekhar will also tell us about cluster infections. Because these questions keep coming. Even a couple of days or weeks back, I had one question addressed to AIOS. Sir, cluster endophthalmitis ho gaya, to kya karna chahiye? So what I'm saying is, these things, people who operate, they keep facing such challenges in life about this infection. So I'll just introduce very briefly. So I hope something is visible here.
Yeah.
Slide deck is visible.
Yeah. I just. So, frankly speaking, you see, we all pray to God when severe infection occurs. But I think every day we have to pray primarily because whatever God has given us. Endoff is a disaster. We all understand it's a disaster, and can happen after trauma, can happen without surgery, without trauma also, and that is through the blood route, that is endogenous endophthalmitis. So today we'll be primarily talking about endophthalmitis, which we see after surgery. So this is very nice looking picture. We see, very good glow, 6x6 vision. But this is a disaster. This is a disaster which, nobody should face. But if not managed in time, and if not managed properly, this can lead to phthisis bulbi. Believe me, this can happen. And all of us clinicians do encounter very rarely this situation of phthisis. But believe me, today, whatever management techniques we have, whatever prophylactic measures we have, and whatever, hospital control requirements or OT sterilization techniques we have, this should not happen in today's era. But if it happens, this is a disaster and can mar a lot of practices. It can shut down. There can be court cases, and there can be, litigations, and these things keep increasing as in the modern era. As I said, incidence is very, very low, but a person who operates a single case is very, very challenging. And if series of cases occur, this is a smile which becomes reverse actually. And this happens to a surgeon who operates. You see, in this era, a lot of people who don't operate, they're always smiling. I don't know, but people who operate, not only the surgeon, not only the patient, but entire family comes to know there's something wrong with this guy today. Why is he not smiling? So these things, I always stress in all the presentations that if we diagnose early, and that will be the thrust of this webinar, to diagnose very early, how to distinguish from, a non-infectious pathology like TAS, and One thing is that we should not do bad mouthing. Never utter this word once you are seeing a patient. "अरे, ये कहाँ पे करवा लिया केस आपने?" Because this bad mouthing, believe me, happens because of us. That means our colleagues only, and this leads to court cases, conviction. And believe me, media is waiting for this, and judges are giving penalty of crores of rupees because of this. And these things, you see, this chart I've deliberately put here, and this couple of books I have put here. All these have been sponsored by, or by educational grant from CIPLA. And when I was secretary, we brought in this endophthalmitis first guideline. Then again, this focus group meeting we had, and this chart twice. I thank Mr. Nitish Pandey of CIPLA and all this wonderful team of CIPLA for having they gave us 18,000 charts, and we distribute these charts all across the country to all the AS members. And this is the flow for today's talk. So we have 5 wonderful people who will be speaking. We'll start with Dr. Nirmal Frederick, who everybody knows. Nirmal Frederick is a doyen. In fact, whenever we recently had Nirmal with the trauma workshop, and he'll be telling us about hospital infection control. Very, very important, because people who are establishing their practices, they should know what are the OT requirements, what are the requirements of sterilization, and you see NABH, whether required, not required. So many things are required before you set up a new practice. And then you see, even if you have established a very good practice, very good hospital, very good ETO sterilization and everything is there, but still you may have infection. And that's the reason we included a talk on prophylaxis. What are the pearls which everybody should know, which can prevent this infection, which can prevent this disaster? And then if this disaster occurs, despite your having a good OT, despite taking many years to prevent it, then whensoever this reaction occurs, should I go inside and give injection, or should I wait? Meaning thereby whether it's inflammatory reaction or it's infectious reaction. Dr. Mallika Goyal from Apollo Hospital, Hyderabad, is a very high volume surgeon there, and she does a lot of good work, and she has a lot of good collection of photograph of not only endophthalmitis but a lot of retinal diseases. And then I will show you a couple of cases. How do we manage these patients? This, which again is a challenge, and every time this fruitful outcome may not occur. And Dr. D.C. D. Chandrasekhar from Coimbatore Arvind Eye Hospital, again a very good speaker, especially on this subject of, and he has been part of all our guidelines. DC will tell us, if you have cluster, what should we do? How should we go about? So with this, I will stop sharing my screen and request Dr. Nirmal to take over and tell us about his hospital infection control, OT requirements, sterilization, and validation. Over to you, Nirmal.
Thank you, President. Thanks for the invitation and introduction. I thank CIPLA and all the organizing team for this wonderful opportunity. I hope my slide is visible.
Yes, Nirmal. Yes, everything is. You can make it full screen.
So I'll be talking to you about hospital infection control, the requirements, and the sterilization and validation. So President has given a wonderful introduction to this topic, and we all know the ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands in times of challenge and controversy. And endophthalmitis is one topic or one case that can really test our skills in terms of challenge and controversy. And of course, when it happens as a cluster, that is the ultimate challenge to us, our practice and our brand image. Brings with it a lot of challenges and controversies. So what should we do? So we need to learn from others' mistake, because life is too short to make them all yourself. So we need to learn from others. So these are some of the paper cuttings and the news reports. And so generally the media tend to exaggerate, and this is the favorite word they use, the botched surgery. And what do we learn from this? So one thing is cataract surgery is considered to be a low risk and easy to perform. I think we need to challenge this thing first. And the second one is the paper has highlighted contracted infection either as a result of lack of proper equipment or because of equipment was not sterilized. So these are some of the things that happen or comes in the media, and this is not the first time cataract surgery has hit the headlines. And this is another incident at Barwani, the sterilizing fluid or the BSS was known to cause the culprit, and they also suggested continuous medical education program on operation theatre sterilization for all the doctors and the team members. So this incident highlighted about the importance of taking diabetes, mellitus, and hypertension under control, and also seeing whether the consumable we use are under proper sterilization, and we also need to monitor their expiry status and the sterilization norms. So this is another incident with Avastin and probably contaminated injections. All this highlights important aspect of prevention, and prevention of disease must become the goal of every physician, because infection, we have to live with it. We continue to live in a world of infection. So how do we control this? So we should not be an ostrich when it comes to infection control. We need to apply our mind and see how we can improve the goodness in healthcare. So any system for the how do we quantify the goodness? We need to understand the structure. The structure is where we deliver the care process. It may be the hospital building, the human resources, the team which delivers the care, the facilities we have, and in eye care, it is mainly the critical care is operation theatre, and the policies, and how do we document and provide those services, and what are the outcomes, whether good outcomes or bad outcomes. So we have to focus on these three important parameters: the structure, process, and the outcomes. So how to design our structure, how to improve our process. So this is the crux of my talk. So instead of giving you the full outline, I thought I'll give you just 8 points to see how we can improve the outcomes by improving the structure, process, outcome. So the infrastructure is much more important than architecture. So we need to strengthen the structure through which we deliver care, and hospital design is a challenging topic. So there are three different functions in this space. So we need to provide safe, comfortable, and calming atmosphere for the patient and the providers, that is the surgical team. And the team has to navigate the space quickly and efficiently. And we also see infection control. So we need to have zoning, proper equipment, sterile surfaces, ventilation, and unidirectional flow. And it is indeed a challenge in small OT areas like us to incorporate all this, and this is where architects and the medical team has to come together to see how we can provide a safe space. So this is one key video. So we need to plan the infrastructure properly. So not only the operation theatre, but also the support systems. So the support systems are very important to provide a safe care. So what are the safe additional requirements? So apart from the structural component, we need to have an emergency exit system, proper electricity for backup. Water supply is very critical from the infection control point of view. And we also need to have good medical gas supply and communication system. So many people, when we ask about hospital design or theatre design, ask about what are the references. So the main reference is the National Building Code, so which has given the requirements for the OT operation theatre as well as the support facilities. These are National Building Code norms and not NABH norms. The second important regulatory requirement is the Clinical Establishment Act, where the zoning is mandatory. We need to have 4 zones in the operation theatre: sterile, clean zone, protective zone, and dirty area. And we also need to give due consideration for appropriate environment for the staff and patients. Apart from this regulatory requirement, there are guidelines given by national NABH, and of course our own All India Ophthalmic Society guidelines, and then the guidelines by the Vision 2020, and of course the National Program for Control of Blindness. And there are umpteen number of articles with all the resources. And this is one article which highlights all those resources, which had almost 61,000 downloads in the last 6 years. So the science of controlling infection is a common mixture of complex mixture of engineering, particle physics, microbiology, and medicine. It's not only pure ophthalmology. So we need to know why infection control failures happen in our systems. So this is a 4 well-defined zone that need to be finalized at the planning stage itself in our operation theater. For single theaters, it will be a difficult job to have 4 well-defined zone. So we have to ensure that there is no mixing of the sterile and unsterile areas. You also need to have a look at the air conditioning and engineering controls. Engineering control plays a major role in prevention of infection. This happens by dilution and also filtration, providing optimal temperature so that the infection or the particles doesn't grow, and also reduces the exposure time to the area, because most of our surgeries have now become keyhole surgeries. And also with the use of airflow patterns and ultraviolet treatment, we can make it more secure. And these are the ideal operating room ventilation parameters: continuous air purifying, temperature around 20 to 23, humidity control has to be there, and also positive pressure ventilation. If you can provide them, it is well and good. So, and these are some of the requirements for the OT walls, door and lighting. You need to have dust proof walls and moisture proof walls. It can be code, and door has to be a self-closing device for evacuation, and floor, any hard material with less joints will do, need not be the modular theater. And you can also have this epoxy or PVC flooring, which is now becoming cheaper. So having a good, well-designed and planned OT is an important requirement, not only from accreditation point of view, but also legal requirement. And it provides better infection control and also safe for all the team as well as patients. The next part is how to improve the process and the outcomes. We need to write down our processes. As doctors, we are all trained for this, but our staff need to be trained. So we need to have a fixed, well-designed program for the entire staff. This can be based on minimum to optimum to full requirements based on your scope of services and the type of surgeries and work you do. An infection control manual really helps in this regard for training our staff and also monitoring them and controlling over a period of time. And the infection control program has to focus on these important parameters: hand hygiene, personal protection devices, instrument disinfection and sterilization, and also now biomedical waste management is becoming a critical area. The next important aspect is risk assessment and monitoring the high risk areas. So monitoring high risk areas in eye care, the operation theater is the high risk areas. We also need to look at how we can reduce the risk in the patients based on patient risk profile as well as surgery risk profile. So you need to, these are the high risk areas in our eye care centers, the operation theaters, the OP areas, the diagnostic areas, and the post-operative ward. And the most important aspect area is CSST, where our instruments are sterilized. We also need to look at the high risk procedures, the lacrimal surgeries, refractive surgeries, oculoplastic surgeries, if there is an element of trauma involved, so there is a high risk of endophthalmitis. And also complicated procedures, we have to be careful. So we need to look at the risk factors and the profile. So this is also important, the microbiological evaluation of various parameters. So we have to do a proper surveillance, not only about the surface aspect of the operation theater, but also the particulate count, especially if you have a laminar airflow theater. The fourth important aspect is we need to strengthen our CSST area. This is the area where we disinfect and do sterilization activities. So you need to segregate these areas. So there should be a unidirectional flow of men, material, and resources. We have to ensure that this dirty zone materials and the sterile zone doesn't mix. So we have to have a control over this. And also we need to have a control over the air conditioning, the ducts, filter, that has to be maintained over a period of time. Water supply quality is very, very important. Ensure that there is no seepage in the plumbing lines. The fourth important aspect is we need to diligently follow the disinfection and sterilization practices, right from decontamination to draining the water, making it a dry pack, and also storing in the sterile storage area. So we need to have a control over this to ensure patient and healthcare workers' safety. So these are some of the pearls. So pre-cleaning at the source of usage. We need to clean the instrument when they are moist, and don't use saline to keep instrument moist. So use BSS or distilled water. Don't disinfect instruments with glutaraldehyde or hypochlorite. So you have to pre-rinse and send, and use appropriate instrument cleaning brushes and appropriate and complete PPE while cleaning. So while packaging, this is very important, and the package should be permeable to the sterilizing agent, whether it's ETO or the steam sterilization, to ensure that we use the right packaging materials. It should resist tears and punctures and also facilitate aseptic presentation of the package. And don't pack unclean instruments, very important, and use a checklist for packing and verifying all type of sets. Don't overload the set, and use appropriate sterilization indicators. So how do we ensure that our sterilization process are streamlined? Many of us there is over reliance on disinfectants and chemicals. We have to use the right chemical or disinfectant in the right quantity and quality, because there's a huge recurrent cost with the usage of chemicals. And also chemical sterilization has to be validated and calibrated properly. It's quite difficult, and it is different from the laboratory testing and real-time hospital conditions. And theater maintenance, use only vacuum cleaners, don't broom, because it increases the bacterial flora in the environment. So cleaning the floor, just use a simple detergent which reduces by 80%. An additional disinfectant like bacillocid reduces to 95%. And stick to one time tested disinfectant. Don't keep on changing, because whatever you do in busy hospitals, the counts raise in 2 hours. So fumigation, many of us continue to do fumigation. It's no longer advocated in modern operation theaters. Exceptions are there after a cluster infections or after shutdown or repair or while commissioning of the OT. Now, coming to the important aspect of sterilizers, we use many agents: steam, plasma, ozone, or ETO gas. Steam is the commonly used. Ideal is to have a Class B autoclave. It's prudent to invest in a good Class B autoclave. You can use various types, wrapped or unwrapped, or porous or non-porous. So the most important machine in OT for infection control is the autoclave. So it's better to invest in a good autoclave. And we also need to have a control over the sterility indicators. So most of us tend to still use only chemical indicators. High time we upgrade and go to a proper control mechanism. We need to control and monitor these 3 important parameters: equipment control, load control, and exposure control. Let me come to this one by one. For exposure control, better to use the 5 and 6 integrators. And monitoring the sterile process, you also need to have a control over the equipment. So ideally, BD test has to be done every day, but there are some deviations. You can use it at least once a week or once in a fortnight, depends on the scope of services and the number of cases you used. And sterility is an important aspect. You can't see sterility, so you need to have a regular validation test for the sterilization. As I said earlier, Class 5 integrator and above is important for every load, for every cycle. And for the safety of handpieces, always better to follow the manufacturing guidelines. So whether it's wrapped or unwrapped, so ensure that you follow the manufacturer guidelines. So you need to have a documented policy for reuse of devices, particularly the number of reuses and the process of reuse, particularly for the phaco tubings and the vitrectomy tubings, and the consumables for serology positive cases. The next important aspect is take action to prevent and control healthcare associated infections. Compliance to hand washing is important, and also usage of PPE, the right quality, right quantity at the right time, and we need to justify the usage of PPE. The last factor is documentation of HIC and sterilization activities. People believe that certain steps don't always matter, and skipping steps can become habitual. This is where documentation really helps. Having a checklist will really help. You need to have a surgical safety checklist and also document all this requirements: equipment control, load control, exposure control, and pack control. So this really helps in reviewing when there is a breakage of sterilization or when there is an endophthalmitis. These are some of the records which are very important from the cluster end of point of view, right from autoclave cleaning register to disinfection register, having a register for emergency drugs, the sterilization registers, as well as the OT stock and purchase register. I'm sure Chandrasekhar will focus more on this documentation part. Maybe the last part is training and auditing our staff. Training and upgrading is very, very important. Not only upgrading our equipment, we need to train our doctors, nurses, paramedical staff, and administration staff on the sterilization failures, hand wash compliances, biomedical wastage segregation. These are some of the do's and don'ts. We need to keep on training our OT technician and nurses and also monitor them. We need to audit and review the infection rates. We have to encourage and incentivize reporting, whether it's TAS, because TAS is underreported, whereas infection is overreported. So we have to ensure that we capture all the data and also follow the outcome indicators to ensure that we reduce, we learn from the mistakes. So what is our responsibility? We need to analyze the infection data, treat people with infectious disease, develop an outbreak action plan, and also keep educating health professionals. So we need to be informed, be prepared, be smart, and be safe to prevent infection in our practice. So the ultimate measure is to stand up and face the challenge and controversy. At the end of the day, the goals are very simple with reference to infection control. It is our safety, our and security, as well as patient safety and security. Thank you so much.
Thank you, Nirmal, for this very important but hurried kind of talk. Because I think we need to spend more time on this talk rather than the subsequent talks, because these are the things which clinicians do not know much, and we keep emphasizing on this. So, Malika, I think we will have 5-10 minute discussion with the topic, because I believe that if we leave it to the end, that never comes. So, you see, Nirmal has emphasized so many things. In fact, I would try to convince CIPLA people that the talk by Nirmal and DC should, or I'll try to convince Namrata Sharma, should be brought out as guideline rather than end of guidelines, which we have brought twice. Because these things, Nirmal, are less emphasized in a lot of these webinars or in-person meetings. But these, I think, are most important. You see, if I may ask you, suppose, a young budding ophthalmologist is going to start his practice. He's not much aware of how to set up the operation theater. Even if he reads all the literature from NPCB or, goes through it, he is not aware of all these things. And that is what is the, all this AC and water sources and, where to build up, how much the area, and all these things, what you have pointed out in your, 10 sermons, are not easily available also. And I would lay stress, in fact, this material should be part and parcel of postgraduate training. And believe me, even at RP Center, even at the Apex Center, nobody teaches you at part of this MD curriculum or MS curriculum these important things. No, Malika?
Yes. I mean, those details which he was in his slides is obviously not taught at all. And somebody setting up needs those details. Definitely.
You see, very important things, we keep listening, but implementation sometimes is lacking. Doctors are busy doing surgeries, CSSD is left to a technician. And although we emphasize once in a couple of months, we will go and, check his register if we are keen. Otherwise, most of these high volume people do not pay attention to this unless they have had this disaster. Then they will go there, what is happening.
Can I add a point here, sir?
Yes.
I think before giving a case to a postgraduate or fellow, we need to ask them to go to the CSSD area, see how they are autoclaving it, and how we can monitor this. So even before washing his hand or preparing for assisting or doing a procedure, he has to go to the back end, see how the instruments are processed, how the instruments are cleaned. And also after the case, he has to stay back and see how it is packed, cleaned, sterilized, and packed. Because after setting up a practice, he is more bothered about the recurring cost related to instruments and maintenance of the machine. So we have to teach this right from the surgical training level.
So no, I wanted to ask how to go about this, because I have emphasized this in a lot of webinars. You see, at Center for Sight, believe me, when a retina fellow joins, first month of his or her training is, I ask them to go to a machine. Don't wash up at all. just see what's going on in the operation theater, what are the aesthetics, how to move around in the operation theater. But these also, are not taught, and they just come in whatever attire or whatever. They may change, that's okay. But OT behavior and etiquettes are not taught.
Yes.
And then I would typically tell them to just see the vitrectomy machine, because I do VRs. So see the machine, put on all the tubing, set up the machine, and keep 2-3 weeks every day. Do this. That because although man behind the machine matters, the machine matters a lot. If the machine breaks down, we keep running after technician. Arey, kya ho gaya? The person should learn. But you have added another point, which although emphasized but not practiced, honestly speaking. Before I gave a surgery to a patient, to this budding surgeon, you see, couple of weeks or maybe days, forcibly tell him or her, by go to CSD room, see how the technician is packing. Sometimes you see these people, because of monotony, they may become lax sometimes, because it does not matter to them. Because naam to mera kharab hona na. So they don't care. They sometimes may become lax. And just to see to it that they are serious about these things. So a visit by even the chairman or this hospital or big people is mandated.
A document like Dr. Nirmal Frederick's talk will also force the management of hospitals to see that it is in black and white and has to be done. When the surgeon tells the management, they think it's just a fuss and without nothing. If it is in black and
because
white,
100% I agree, because this document has to be prepared, given to the the managerial person, to the chairman of the hospital, to all the all the surgeons, and very important is repeatedly again it has to be hammered again. Once is not enough, because we will remember how to do phaco or VR, but we'll forget about all these indicators and all this. Still, you see, I keep seeing sometimes fumigation in some areas and chemical sterilization, although chemical sterilization is totally out nowadays, but people keep doing. One other question, Nirmal, was about the reuse, because developed countries is a different issue. Developing countries often, whether it is phaco or VR, we tend to reuse, and this tends to compromise not only the sharpness of instrument but also poses a threat to sterility. Your take on that?
Yes, when we started work on the NABH eye care standard, we had a lot of discussion on the reuse policy, the consumables as well as the tubings. There are resources that the tubings over a period of time becomes non-pliable and affects the quality of surgery. One. Second, over a period of time, the internal surface of the tubings become rough and becomes a nidus for the infective particles. So we are adding a complexity as well as risk to the patient by reusing. So by reusing, we have to set a trend. So there are single-use devices and tubings. So there are multiple-use tubings also. We have to set a line how many times we need to reuse. So some of the companies have this policy, don't reuse beyond 5 times or 25 times. But our people don't listen to this for various reasons, cost control as well.
Is there any consensus? Because company walas will definitely tell us, every time open a new pack. But because of economic reasons, because a lot of our patients have to pay from their pocket, insurance penetration is only 15-20%.
Yes.
So is there any consensus like 5 times?
Yeah, we need to see the quality of the tubings as well as the hand pieces, and accordingly we have to see what is the maximum number of sterilization that can
even like you rightly said, I can't see, eyes can't see what is the quality. That is my point. You see, I am telling you, because from outside I can't tell whether a cutter is working. So what I made a policy was, in my hospital, 5 times thank you. Throw it even if it is functioning. Otherwise, believe me, we tend till the time it stops cutting. Like we have a razor, when we shave, till the time its skin starts bleeding, we don't throw away the.
So the single-use FMS, that is a good concept. The only factor in India is the cost factor.
Yes.
Because we are sure of the quality, we are sure of the machine that is going to work. And once it's disposed, we are sure of the infection control and the nil risk with reference to the tubings and the FMS system.
So
but when it comes to reuse, there are people who are using it 100 times. till it really stops functioning. So there are people who have hospital which don't use beyond 10 times or 25 times.
So there
we
is no
have to get it
consensus.
from,
There's no consensus.
that is where manufacturer guidelines come, because manufacturer, based on the materials they use for the tubings and also the internal surface over a period of so many autoclaves, and also the type of autoclave, whether it is ETO or whether it is autoclave, steam sterilization or plasma sterilization. So we have to validate the internal tubing system, and that is the reason why we say follow the manufacturer guidelines. And of course, manufacturer, they have their own devious policy because of the costing issues.
So Nirmal, you stress a lot about OT, operation theatre designing and other things. One question from Dr. Chaitanya from Maharashtra is that is ophthalmic surgery, should it be done in a multi-specialty hospital? You know, suppose an orthopedics case who in one of the operation theatre. Maybe I'll ask Mallika also because she practices in a multi-specialty hospital. What requirements does the OT need? Is a modular OT with laminate, flow and HEPA filter adequate or a must?
Okay, I'll come one by one.
Yeah.
There was a time when NPCB issued a mandate that ophthalmic surgery should be done only in a exclusive eye operation theatre. I think that mandate has been withdrawn, not because that was after a cluster endophthalmitis that happened in a multi-specialty hospital. So doing a eye surgery in a multi-specialty can be done, provided if there is an adequate window between the two surgeries, there is a good infection control system in the multi-specialty theatre, and preferably the first case where there is no risk of septic case before. So this is where problem happens. In multi-specialty, we can't see what is the first case done. It might be a fistula, and I know this, or some other complex septic cases. So if there is a breakage in the infection control system, there is a high risk. That is the reason. So we have to focus on the type of surgery being done in that theatre. And second, we have to oversee the infection control system, disinfection as well as the sterilization packages. So in that case, you can definitely do in a multi-specialty theatre.
Mallika, you would like to add something to this because you operate in a big multi-specialty hospital?
Yeah, I think he has covered the points that it should not have been an infected case. You should know the type of case which was done. If it was a gastric surgery or a gastrointestinal surgery, it's obviously a contaminated surgery. They may say it was not infected, but it is contaminated, so we don't want to follow that.
So will you cancel your case agar pehle gastric surgery hua and what?
Yes. It should be either an arthroscopy or something clean. Clean surgery is fine. But no, otherwise no, because there's a high risk of infection. It could be the first case in a multi-speciality OT. You could be the first case, that's fine. Or you have to follow a good, or there should be some kind of fumigation kind of procedure between the two cases. If it was not an infected case, but it was possibly contaminated in terms of gastric surgery, at least some kind of sterilization procedure between your case and the next case can be.
Is that procedure an eye wash or usne aake kar diya kuch and you believe or you test that, or how do you go about that? Because in Apollo, I'm telling you, we used to repeatedly fight with our sister that pehla case eye color. We used to fight, but sometimes you cannot. So what the technician will do is he will come and open the theater and do some jhadu pocha there and maybe walls. If I'm standing there, he will do cleanly. If I'm not standing there, he will just do an eye wash. Sir, ho gaya.
Yeah, no, but in Apollo here, at least there's an IoT. We don't have to go to other OTs at all. But there is something they use as some kind of a fumigant. It's not the conventional formaldehyde fumigation, but there is some newer way they use.
So there are systems.
There are aldehyde chemicals.
Aldehyde, yeah.
There are newer aldehyde chemicals like Incidor, Vercon, and Bacillocid was also used because of the stickiness and corrosiveness. We now stick to Desbac, which is D125.
Yes,
so relatively corrosion free. So these are newer chemicals.
So I think,
So what I suggest between the surgeries is a thorough surface disinfection. Second, surface disinfection of the equipment we use. So this is where it can get contaminated because the equipment stays there during the previous procedure also. So the surface have to be clean. and the entire surgical team has to wash and get prepared freshly. So including the nursing staff, they also have to doff and then rewash for the case.
Yeah. Very important. Very important. DC, you want to add anything? We'll move on.
Yes, sir. Yes, sir. I worked with the medical college as well as a multi-specialty hospital, which is NABH accredited. Basically, in a multi-specialty hospital, ideal would be to have a dedicated OT, sir. But if that unit is doing many surgeries, then a dedicated OT would be a problem. Because I've seen a few incidents where after a non-ophthalmic surgery, even the day after, end-off has come because of the source from the primary non-ophthalmic surgery.
The problem is all this multi-specialty big chains, unless you are Mallika Goel or unless you have a high volume of cases,
correct, sir,
they will not give you a first case because they are, run after revenue. So my issue is that, you see, if you have 10, 20 surgeries, they will give, but otherwise they will force you to wait because it's a small procedure. They will ask you to, come after some time or whatever. In any case, I think we can't keep fighting with the management. Some points which Nirmal said and Mallika also said, that try to have first case or do surface disinfection and thorough, change of the team. In fact, we can ask the next nursing staff to come. Equipment. Yes, Mallika.
So can I add? I think there is a question.
Yeah.
Yes, Mallika. There is a question on modular OT with a laminar airflow and HEPA filter adequate.
Yes.
So in a multi-specialty hospital, if there is a laminar airflow and HEPA filter, so you need to allow enough time between the surgeries because the air exchanges has to take place, the pressure gradient has to build up, and the temperature have to be monitored. So if you are able to monitor these three parameters, you can definitely do the next case. And of course, with the guidelines we have discussed before.
So we should wait for 10-20 minutes for this air exchanges to occur, or?
Yes. Between the two cases, there has to be minimum 15 to 20 minutes because it depends on the air exchange. For a super specialty theatre, the number of air exchange would be 25 to 30. For a regular theatre, would be 15 air exchanges. So we have to wait at least for 15 to 30 minutes. And this also requires cleaning time because the surface disinfection needs at least 15 to 20 minutes. So if we can wait for this and the process takes place over a period of 20 to 30 minutes, then we are relatively safe.
Yes, Mallika, you wanted to say something?
Yeah, just to answer that question properly, it is feasible to operate in a multi-speciality OT, but not at all advisable. And so, by and large, there should be a lobbying for a separate eye operation theatre. It's not at all advisable because we cannot keep on spying on what was the previous case, whether it was contaminated or not. We really don't know the extent of.
Yeah, I agree with you. Why should we increase our blood pressure by spying on this thing and these people? And I agree with DC that and Mallika that we should somehow hammer into the management that, or if at all you can't have a separate, at least have the first case. So with this, a lot of useful inputs. Thank Nirmal, for this wonderful inputs. And now I think we move on to Dr. Mallika because I don't think so. Namrata has joined. So in any case, whenever she joins, we will talk to her. So we had requested Mallika to speak primarily on very important topic of TAS versus infection or non-inflammatory, non-infectious versus infectious, because at times the situation is very clear. At times the situation is hazy or blurred. And what to do in those scenarios, I'll request Mallika to please tell us.
Yes. Thank you very much, sir, for this opportunity. So the question is, post-surgical inflammation, is it sterile or infective? So why is it important to differentiate? Because the management of these two is diagonally opposed. Sterile inflammation is treated with steroids, whereas endophthalmitis is an emergency and needs urgent intervention with antibiotics. And in fact, steroids are contraindicated. So the treatment is opposed. And further, the endophthalmitis has a very guarded prognosis if there is delay in treatment. This is just an interesting case we had a few years back, which was we thought this was a post-operative endophthalmitis because of inflammation. But actually it turned out that there was a cysticercus behind the iris which was causing the recurrent inflammation. And this resolved after removing the cysticercus. So that's the importance of identifying the etiology. Now, what's the difference between a sterile inflammation, which could be the severe toxic anterior segment syndrome, or TAS, and endophthalmitis? TAS is inflammation in the anterior segment in response to a non-infectious toxic substance, whereas endophthalmitis is live organisms, bacteria and fungus, in the eye with inflammation in the entire ocular cavity involving the vitreous as well. So what are the causes of TAS? The most important causes are inadequate cleaning of the instruments, inadequate flushing of the phaco and other handpieces, which should be flushed post-surgery with about 120 cc of distilled water, or residual detergents on the cleaned instruments, which requires adequate rinsing after the detergents, or residual denatured material from the previous surgery on the instruments, like viscoelastic agents, preservatives in the injected medication, particularly the benzalkonium chloride, which is the commonest, and which not only causes inflammation but also is toxic to the endothelium. Changes in the composition of fluids which are injected, intracameral antibiotics can cause TAS, or dyes that are injected, silicone oil can cause TAS, or gloves which are powdered or even unpowdered gloves can cause. Contact of gloves with the IOL should be avoided, that can cause. Eye ointments at the end of surgery can find their way into the anterior chamber. And endotoxin contamination, which usually comes from ultrasound baths or any liquid source. Now, how to diagnose infection versus sterile inflammation? There is no rule of thumb to diagnose, and it is a combination of several factors that has to be taken into account, including sometimes we have to give a therapeutic trial. So basically, TAS is an acute inflammatory response to a non-infectious substance developing within 12 to 48 hours, usually on the first post-operative day, and not only after surgery, but even after intravitreal injections. It can be characterized by diffuse limbus to limbus corneal edema, with vitreous being relatively uninvolved and responding to steroids in most cases. Whereas endophthalmitis is an infection presenting usually after 3 to 5 days of surgery, and usually within 2 weeks, though it can be within 6 weeks or even later. Pain is frequent, unlike TAS, and there is significant vitreous involvement. Now, clues to diagnosis can start with the patient profile. If the patient is a diabetic, immunosuppressed, or of advanced age, they have low immunity and infection is more likely. If there is a history of uveitis, it is more likely sterile inflammation. Clusters are more often seen with TAS than with infection. Then clues from the operation notes. If it was a traumatic surgery, prolonged surgery, it's more likely non-infective inflammation. Or if there is retained cortical matter or a nuclear fragment, it's non-infective. Infective etiology can be seen with an uneventful surgery, though a PC rupture or a vitreous disturbance increases the risk dramatically. So as we mentioned, onset time is very important, and there are various other factors which help in distinguishing between the two, which I will elaborate on each point now. So the timing of onset, TAS is almost always on the first postoperative day, and alone this finding is not definitive, because TAS can also present as a delayed onset inflammation, whereas infections can present on day one as well if it is very severe and fulminant infection. Now, delayed onset TAS has been reported several times and usually related to the IOL material, the polishing material. And this, again, when it is delayed onset, it can mimic a fungal endophthalmitis or a P. acnes endophthalmitis. And unfortunately, these late onset infections also respond to steroids initially. So again, the differentiation becomes difficult. Pain indicates an infection. However, up to 14% of the cases of infection may not have pain. TAS is less often associated with pain unless the IOP is very high. So 10% of TAS eyes versus 75% of infection will have pain. Similarly, conjunctival and lid infection are more commonly seen with endophthalmitis than with TAS. So you can see chemosis is in 40% of TAS versus 80% of endophthalmitis. But there are no absolute numbers. So you can have these features in one or the other. So again, these are not absolute differentiating points. Now, endophthalmitis can also happen with a white eye, painless eye, when the patient is on immunosuppressives or when the infection has followed an intravitreal steroid, um, where steroid has been used during the vitreous surgery. So high index of suspicion is required even in a painless white eye. And delay worsens the prognosis. For example, this is a patient with Mooren's ulcer on immunosuppression and developed endophthalmitis post-Capro, but the diagnosis was delayed because the eye was painless and white. So that when we finally operate them, they are full of exudates and the prognosis is worse. Similarly, a post-IVTA 5 months and post 7 weeks dexamethasone, white eye, painless, but full of exudates. So painless white eye is not always sterile inflammation. It can be infective. Corneal edema favors sterile inflammation, which could be either from trauma, which will be a localized corneal edema, versus TAS, which will be a limbus to limbus diffuse edema. Other features that favor endophthalmitis are fibrin or membrane in the AC, which is seen in 20% of, which can also be seen in 20 to 40% of TAS cases. Hypopyon, which is less common in TAS and much more common in endophthalmitis, and anterior vitreous opacities or even posterior opacities, which are much more common in infection and only in 20% of TAS eyes. This is to show an example of an inflammatory pupillary membrane, infective actually. This was an aspergillus. This membrane was causing angle closure repeatedly, and despite multiple YAG iridotomies, it underwent a removal of the membrane with surgical iridotomy, despite which it kept recurring and finally required removal of IOL. Infective foci, if they are seen near the eye or wound abscess, then they are in favor of infection. Similarly, a wound leak favors infection. Iris damage is a feature of TAS and is unlikely in endophthalmitis. A dilated pupil is also a feature of TAS. Raised IOP can be seen in TAS because of toxicity to the trabecular meshwork. Unless the inflammation is very severe, then you can have hypotony. A detailed posterior segment evaluation, including indirect ophthalmoscopy, if it shows some exudates, it suggests infection, but not always. I have seen patients with dense vitreous opacities, but those were ultimately sterile inflammation, did not require any intervention. Retinal hemorrhages are almost pathognomonic of infection. A dropped lens matter or a nuclear fragment favors sterile inflammation. Vitreous involvement strongly in favor of infection. And if there's no view, a B-scan can give the idea. However, up to 25% of non-infective cases can have significant vitreous involvement. This is very important to remember. And finally, therapeutic response to steroids favors sterile inflammations. When in doubt, you can start topical steroids every half an hour to 1 hour, with or without oral steroids if it is a severe case, and monitor the patient after 6 hours. Ask the patient to wait in the OPD. Keep seeing them through the day. And again, if they're not worse, by the end of the day, continue the same, but see them again the next day. Because even infection can respond to steroids initially. So unless we are sure, only gradually wean off the patient from the examinations to be very certain. So as a summary, between the two diagnoses, pain is a feature of endophthalmitis. Raised IOP suggests TAS. Early onset, very early onset, day 1 is in favor of TAS. A diffuse kind of edema is in favor of TAS. Severe fibrin exudation, hypopyon or membranes are in favor of infection. Vitreous involvement is in favor of infection. And TAS improves in response to steroids, whereas endophthalmitis will respond only to antibiotics or antifungals. And finally, if we are not sure and we have done an intervention, if there is a positive culture result that confirms the infection, a negative result does not rule out infection because 30 to 40% of infections can be culture negative. Thank you.
Thank you, Malika, for this very important talk because this is confusing. This is confusing. And I think all of us, including myself, have made errors on this.
Yes.
So if although I believe surgeon is the most important person who will tell us how much fiddling he did with iris and how much time he took. I normally ask this patient, surgery mein kitna time laga tha? If it's a clean surgery, it will come out in say 10 minutes or so. But if the surgeon has struggled and taken for a cataract surgeon, for a cataract surgery more than half an hour, 45 minutes, that means something wrong is going on, and you expect some reaction on day one. So that is one clue which I keep ask the patient indirectly, because surgeon will never tell. They will always tell uneventful surgery was done. So is there something like posterior TAS also?
Yes,
Like
yes.
this is the anterior TAS.
Yes, yes. It can very much involve the posterior segment. And I have also seen patients with frank vitreous opacities or exudates, which you can call it. And I told the patient there is no way you will clear without immediate surgery because it is infective. And to my embarrassment, he cleared just on steroids. Somebody, other doctor was also treating him and with oral steroids, and he cleared completely till this date. This is a few months back. So, and I've seen other cases as well of vitreous involvement which clear without intervention.
So other thing which you have emphasized, but suppose you have seen the patient in the OPD and you diagnose a task based on limbus edema, early onset, day one, and IOP may be slightly higher, and your first diagnostic task, then you treat the IOP as well as give steroids, and then you said you ask the patient to wait in the OPD.
Yes, if the suspicion for infection is strong enough, we should see them again after 6 to 8 hours at least towards the end of the OPD, so that if we want to intervene, we can take them for the injection the same day, IOAB, if he's worsening. If he's improving, then we have a moral right to call him next day. But if he's worsening, we have to intervene same day. Even if we are over treating, it's better to inject same day.
Okay. DC, you wanted to say something?
Yes, sir. I'll take 3 minutes to say an incident. I was going to a secondary center to operate. So on day one, I go to see the post-ops also. It is about 1.5 hours drive. It is a missionary hospital. And on day one, out of possible 15 cases operated that day by two of us, 10 of them had reaction. So my first thought was it is end off. The edema was very limbus to limbus. There was no doubt about it. But there was membrane and exudates in the anterior chamber. And on day one, sir, on day one. And the pain was there, and the B scan did not reveal anything except for very high gain, minimal anterior cells.
So B scan on day one day one will not, because
I know, sir. I am aware. So then again, what we did is we gave steroids. We gave them subconjunctival steroids that day, put them on cycloplegics and passed the ice and applied the drops. By evening, my colleague who stays there called and said it is coming out very well. There is no problem. Patients are happy except 2-3 patients. AC reaction is reduced. So it gave us a relief. And the next day morning, all of them were fine, sir. It was a case of cluster TAS. Actually, it was a secondary center. We didn't know. We kept them for one more day. But as madam says, at least 2 rounds on the same day is important. But we did see again in the afternoon and evening, the improvement was there. And the patients got discharged on second day post-op in the evening. No problems at all. After another 6 months, same thing happened. Out of possible 24 cases, 12 cases had a reaction. So again, first post-op day I was there, we saw. It looked exactly almost similar, except the exudation was little more. So we started the same kind of treatment, everything. And evening, relatively, he said out of the 12 patients, 4 or 5 are improving, but the reactions are less. But exudates are there, membrane is there. Same steroid and antibiotic was there, but we were hoping for the best. But the next day, it turned out all the 12 were Pseudomonas end off. The corneal infiltrate came and it became a full-blown end off. So the steroids, did suppress the initial inflammation, sir. So definitely we need to give a lot of importance to TAS and never forget that it is likely to be a infection also. Then again, unfortunately, it turned out to be Pseudomonas. We had a challenge and then it became a lot of issues, which I'll be probably talking indirectly in my talks. So we need to give importance. We don't take it for granted that this is TAS only. We need to have, and the rounds on the same day, it'll come immediately. We need to see 3 times at least to make sure. Otherwise, the same day intravitreal will be much more effective than the next day intravitreal. I thought I will tell this.
So there are some audience questions. So you are muted. You are muted.
Sorry. I was speaking on this. So I've just noted down the audience. Let's address audience question more than we keep talking amongst ourselves. This gentleman from Uttar Pradesh, Dr. Lalit, wants to know, Nirmal, anybody can react. Use of acetone for cleaning of instruments in between surgery. Is it okay?
Now, as I said, chemical sterilization or disinfection is not really advocated unless it is a dire emergency. So even then, we advocate the use of statin or flash autoclaves rather than using a chemical. Second, rinsing with sterile, no, it is not going to wash all the chemical residues. So it will cause either it will not this itself can lead to TAS, because chemical TAS is a known factor with ETO as well as all the chemical agents that we use for disinfection.
So very well said, Lalit Kumar ji, Uttar Pradesh. Believe me, this chemical sterilization, ekdam red line se cross karna hai. We don't have to, depend on this. You may get away sometimes, but that does not mean this should never become the norm. You see, when we were junior residents at RP Center, we used to put instruments in the side decks also and reuse. But I think God helped at that time. But believe me, in today's era, you cannot depend on chemical sterilization at all. And rinsing also is absolutely is basically an eye wash. So Nirmal, another question, same delegate is still not convinced. Is she, Chaitanya wants to know about what is adequate window. I think you suggested that, 25 to 30 minutes or so much exchange should happen. What is the current opinion regarding intracameral antibiotic? We will come to that, Chaitanya, about this. But if you want one word on this, see, although the house is divided, not only India, but the whole world is divided, whether we should be routinely using intracameral antibiotic or not. In high-risk cases like immunosuppressed or maybe PCR, or where there's a compromise, then you may. But you see, I wrote in endophthalmitis guidelines, left to discretion of the surgeon. So recently, David Chang has reacted and he convened a 10-country meeting on that article, Nirmal, which we wrote in IGO and also published, that with what authority you are saying this. So because you see, Haripriya published a huge, 2 million eyes and showed a definite positive effect. And cefuroxime from Europe also, they showed. But world primarily, you see, I've seen a lot of surgeons have started giving intracameral. But I also know of a lot of institutes who do not give. So world is divided. So current opinion regarding intracameral is a divided opinion, but we leave it to discretion of surgeon. But if you ask me, my personal thing, in all my relatives, whenever they get operated, I ask the surgeon to please give intracameral, because that may be a benefit. Because we always believe the endophthalmitis organisms, they enter at the time of surgery. Because once you make cut, some organisms will go inside. Then depending on the, tolerability or immunity or whatever, what is the load of the organism which has gone inside, it depends whether it will turn out to be a clinical picture or not. But believe me, because the organisms go right at the time of surgery, and it makes theoretical sense at least to kill them with antibiotic. So most commonly practiced is moxifloss, and a lot of companies, including Cipla, have come out with this moxisip. So anybody else wants to, Nirmal, Malika, or DC want to say about preventive aspect, about whether to give Vigamox or not, or moxisip or not? One word, Nirmal.
Yeah, intracameral I use for all high-risk cases, diabetic patients. So we have defined high-risk cases as patients with comorbidities, diabetes, CKD, and lid infections and
Lid infections we will not operate.
intraoperative complications, whether treated or not.
So let's say diabetic, immunocompromised, and intraoperative issues, you should definitely.
Yes.
DC, one word.
Yes,
we
sir.
Don't want
no, sir. At Aravind, we have seen a fourfold decrease, sir. From 0.08 to 0.02, as the study you mentioned, across the system, sir.
Malika, your take? Yes, no? Muted.
I'm not a cataract surgeon, so really, I would say that if your techniques are very good, I don't think you need to really add one more agent with its own complications that additional step can introduce infection and TAS and other things. So I feel if your techniques are good, not required. And I use Moxisip mostly instead of any other drug, the Cipla
Yeah.
Moxiflox.
Yeah. So I agree because I told you in the beginning also the opinion is divided. So Dr. Chaitanya, we still cannot come out with one word that it has to be done. Except I would agree with Nirmal that in high risk patients you should in fact. In fact, Malika, even if you give this additional procedure, that itself can cause TAS.
That's what I'm saying.
That's
That's
right.
what I said. There's another question about not using preoperative antibiotic drops. What is the legal value if endophthalmitis occurs?
So, Nirmal, what is your take?
Yeah.
Any legal issue on this in case I have not used?
No. There are a couple of things about this. If in your hospital policy, if you have preoperative antibiotic as part of your policy, you can continue with that. So there is a concept called standard of care. If everybody in your region uses preoperative antibiotic drop and your hospital policy says, you have to follow that. On the other hand, if you are a single practitioner doesn't have or believe in this, then there is no legal value as such.
No, my take is hospital policy is devised by us only. No?
Yeah.
So, what is your hospital policy? Should we or should we not?
No, I don't have. In our hospital, we don't believe in preoperative antibiotic.
Yeah, I also agree with you, Nirmal. In fact, I do not insist at all. I just, ask them to come dilated. That's all. Even though most of the catheter surgeon, they will give for 1 or 2 days, but there's no evidence to say it at all. In fact, other things are important, like Malika was saying, rather than depending on preoperative antibiotics. In fact, betadine is more important. Isolating lashes is more important. Telling the patient that have a head bath shampoo on the one day on the day of surgery and cleaning with soap and water, that is more important than putting antibiotics.
His
So that
question
is
is about the legality. I think legality, there is no evidence in the literature to say that it is required. So there cannot be a legal case against the doctor.
so. Mona Lisa, I think
We had one issue on this because the hospital has a policy of giving preoperative antibiotic as part of their antibiotic policy. One of the surgeons didn't give the antibiotic drop. So he was questioned about this standard of care, that he is not practiced the standard of care. So that's the reason I said, if you are working in a hospital or institution which has a policy, you have to follow that. Or if it's an independent practice or a small practice where you decide the policy, and if you believe that antibiotic doesn't help, no point in giving it.
So you mean to say can I be taken to court if Mahipal की policy में लिखा हुआ है antibiotic drops and I don't use and my patient develops end off?
Not really. If there is a policy from the hospital that we have to give preoperative antibiotic, particularly in a multi-specialty setting, most of the hospital has this policy, antibiotic prophylaxis for all surgeries. So in that case,
I agree. Nirmal, legal issue तो नहीं है इसमें.
No, it's not legal. What it means is the management can question.
Yeah,
that's okay. That's okay.
वो तो रोज ही करते हैं question.
Yeah, वो तो वैसे भी कुछ. So other question is very important from Haryana Hisar, Dr. Aparna. How to reconstitute a task force? That's a very big job for Namrata Sharma only. She has just joined from Nashik, although late.
so welcoming her with the question.
Yeah.
No, I'm
so
sorry.
in any case, this is a task for her. In fact, Namrata, that how to constitute task force for investigating post-op. In fact, Aparna, we will maybe partly address this question after Namrata's talk and after DC's talk also, because he's going to tell a lot about this. In any case, we will at AIUS, after this request, maybe Sipla, Nitish Pandey and Pooja to help us in constituting a task force also, as well as I had said in the beginning, about Nirmal's talk as well as DC talk to somehow include in focus group meeting of AS guidelines, that setting up of an OT, preparing an OT, and investigating cluster endo. So with these few words, I think let's welcome our Honorary Secretary of AIUS, Namrata, who has finally joined it. I know she never misses, even though she may be late, but she never misses. She wrote to me that she's preoccupied in MOS and sitting on the dais. Maybe they're also addressing ophthalmologist as a inaugural function. But I appreciate, Namrata, of your joining. And your talk is again very, very relevant. You see, Nirmal has stressed about hospital infection control, and then Malika has told us about whether it's inflammation or infection. But your talk also is very, very important because one question had already come regarding prophylactic, use of intracameral antibiotic. So we did answer on your behalf, but we would like to listen from you. The how can we prevent, if at all? What are the pearls to prevent and prophylaxis of post-operative endophthalmitis? So over to you, Namrata.
Thank you so much, sir. And I do apologize for joining in late. I would be talking to you about the prophylaxis of endophthalmitis, and I think we all know that cataract surgery is the most commonly performed intraocular surgery, and incidence of endophthalmitis is 0.05 to 0.1%. And it has been decreasing over the last decade as the practice patterns have been changing, and also because of the fact that there have been guidelines which people have been following. So as far as the endophthalmitis is concerned, it could be either sporadic, which is because of the contamination from the patient's own conjunctival flora, or deficiency of aseptic protocols like pre-op antibiotics, gloving, gowning, patient hygiene, OT ventilation system, and surgical techniques. Or it could be a cluster endophthalmitis, which is generally due to sterilization failure or contaminated surgical supplies. Now, worldwide, coagulase negative staph is the one which is the commonest organism, followed by staph and then streptococci. Gram-negative bacteria are also responsible, like Pseudomonas aeruginosa and fungi. And in India, if you look at the spectrum, it is gram-negative infections and fungal infections. I think for a person who's dealing with infections, it is very important to know geographically where you're located, because that has a bearing on the organisms which can cause endophthalmitis. Preoperatively, there are preventive measures such as use of topical antibiotic, povidone iodine instillation in conjunctival sac for 5 minutes, intraoperative intracameral antibiotic, and postoperative topical antibiotic as well. There are various types of antibiotics which have been used perioperatively, such as fluoroquinolone, aminoglycosides, cephalosporins, chloramphenicol. The route of the administration can vary from time to time, such as topical, intraocular, subconjunctival, and oral. And the timing of the antibiotics is important, that is preoperative, intraoperative, perioperative, and postoperative. The prophylaxis has to occur at all levels, whether it is operation theatre, and for that, operation theatre layout should be good. Patient screening and precautions have to be taken. Then general and ocular examination of the patient is important. And so is the operation theatre preparation as well as the postoperative measures. Operation theatre, of course, I know there would be an overlap, but has to be a dedicated functional eye care facility with separate emergency OT and separate septic OT. And various zones have been defined. The level 1, which is the clean zone, which has restricted entry. Level 2, which is the aseptic zone, which has entry only after changing for both patients and the staff. Level 3, which is again the aseptic zone, which is a sterile area. Again, entry is restricted to minimal staff, and that area has to be fumigated. And level 4, which is the disposal zone for waste disposal, sterilization room, and for instrument maintenance. General examination is important, and blood pressure should be generally less than 160/95. The blood sugar levels have to be, fasting blood sugar should be less than 140, the postprandial less than 200. ECG should be done for all cases, and also urine routine microscopy and albumin. One has to check for systemic illness. They can have a bearing, especially diabetes, hypertension, COPD, cardiovascular condition, renal conditions, etc. And physician consultation should be done before surgery. As far as the ocular examination is concerned, one has to be more careful in one-eyed patients, but slit lamp biomicroscopy should be done. IOP should be checked. The patency of the NLD has to be looked into. Syringing should not be done on the day of surgery. Adnexal infections, if present, have to be treated. Lid conditions and sac-related conditions have to be dealt with first, and then only the intraocular surgery should be taken. Intraocular surgery generally can be delayed by at least 3 weeks after the extraocular surgeries. all investigations, including the contact biometry, should be done at least 1 day prior to the surgery, and one should avoid contact procedures on the day of surgery. Then, of course, preoperative antibiotics is something that almost everybody gives, if not uh, uh, 3 days before the surgery, at least 1 day before the surgery, and also on the day of the surgery. Then written informed consent should be taken in all cases after explaining the procedure and the risks involved, and ocular and facial hygiene is important. I think this is something, as surgeons, we all know how to do the washing and scrubbing, which is taught to us as we enter the discipline of medicine, right, in MBBS, and more so if you've taken surgical branches. There is a way of wearing your gloves with a non-touch technique so that you do not touch your bare hands anywhere. And also there is a way of gloving as well as of wearing the gowns. Now, during surgery, the wounds which are unstable and leak should be sutured to avoid hypotony. Topical fluoroquinolone can be instilled in the conjunctival sac. And intracameral antibiotics, some people like to give it for all cases and others only give it for complicated cases. Post-operatively, proper lid hygiene should be maintained with topical fluoroquinolones or topical antibiotics which are given for at least 7 to 10 days, topical steroids which are tapered for 6 to 8 weeks, cycloplegics if required, wear protective dark glasses outdoors, and regular follow-up is required on the first post-operative day, second or seventh day, and 30 to 25th day with refractive correction. Whenever there is any excessive pain or redness, watering, discharge, or sudden blurring of vision, or floaters or flashes, then emergency consultation should be sought. The signs are known to all of us as ophthalmologists, which include congestion, AC flare in cells, hypopyon, reduced fundal glow, and vitreous exudates. As far as the intracameral antibiotics are concerned, this is the ASCRS Endophthalmitis Prophylaxis Survey. And this is just to show that from respondents who said that they would be using intracameral antibiotics 30% in 2007, this has increased to 84% in 2014. They said that if it becomes available, they would be using it. Now, rationale for using intracameral antibiotics is that the corneal incisions may permit influx of fluid during the surgery, even after hydration of the main wound and the side port. And in spite of using the pre-op antibiotics, rate of intraocular bacterial contamination is 31%. Injecting antibiotics intracamerally intends to kill the bacterial microbes that have been introduced during the procedure. And one of the strongest risk factors for infectious endophthalmitis is a posterior capsular tear. So the antibiotics which have been used are cefuroxime, moxifloxacin, vancomycin, and cefazolin. And the ESCRS study used the cefuroxime, and the evidence was so strong that it had to stop the study in between. Vancomycin used to be used routinely, but cases of HORV have been reported with this, so it was given up. Also, there have been cases of vancomycin associated hemorrhagic retinal vasculitis. 36 eyes were reported way back in 2017, and I think there are many more which have been reported after that. Now, the evidence for intracameral moxifloxacin has been quite strong in retrospective studies. Retrospective study which was done in Arvind Eye Care Hospital has clearly shown that the chances of endophthalmitis are much less. And this is analysis of 600,000 studies, which was again retrospective, which has shown similarly. A study was also done in Japan, which has shown that intracameral moxifloxacin is quite safe and should be administered. And this was another study which looked at the safety of prophylactic intracameral moxifloxacin. And in terms of visual rehabilitation, anterior chamber reaction, pachymetry, and corneal endothelial cell density, it was found to be safe and efficacious both. Then again, this study looked at 250 microgram per 0.05 ml of intracameral injection of moxifloxacin, which again showed that it is quite safe. And this study looked at the cost-effective analysis and said that it is also quite cost-effective. Now, another study which came later in 2019 looked at large number of patients, again said that the PCR increased the overall endophthalmitis rate by more than 7 times. and the intracameral moxifloxacin reduced the rate of endophthalmitis to 0.18% when it was used. These are the AIOS guidelines to prevent intraocular infection, which have been circulated by the All India Ophthalmological Society. There is also a guideline on the cluster endophthalmitis, which also would be circulated. Then this was the All India Ophthalmological Society survey done way back in 2017 to show that 30.2% of the people who are actually at that point in time already using intracameral moxifloxacin. And as compared to the ASCR survey, there was similarity in decision for pre and post-op antibiotics and intracameral antibiotics, but there was dissimilarity in the choice of intracameral antibiotic and decision for subconjunctival antibiotics, which in India, the usage of which was much more as compared to intracameral antibiotics. Now, this is just to show the differences of the two survey, that subconjunctival was being used more by Indian ophthalmologists as compared to the American ophthalmologists. So to conclude, I think proper protocols need to be followed for OT, patient screening and precautions, OT preparation, pre-operative, intraoperative, and post-operative antibiotics usage as well. And it is important to prevent the endophthalmitis and the loss of the eye. I would like to conclude by saying that we've completed a randomized control study in more than 15,000 patients between RP Center and Chitrakoot Hospital, Sadhguru Hospital in Chitrakoot. And it is a prospective randomized control study in which CIPLA did support us, and we are going to publish the results very soon. So thank you very much for your kind attention.
Thank you, Namrata, for this great talk. Although I've heard before, but still every time there is a new learning from this talk. And that's the reason in my intro I said this subject needs to be hammered again and again. So again, couple of questions, which have cropped up. Lalit Kumar has thanked. Has Rajesh Sinha joined because he was...
Sir,
Okay.
sir, I
Rajesh,
also wanted to ask a couple of questions. It was a wonderful presentation I was going through.
So let us
I
first
had a
answer. Maybe let's first answer the audience question because they are more
Yes,
important for me
Yes,
rather than panelists asking.
yes.
Because I think all of us are, here primarily for the purpose of audience. So we will take up Rajesh your comments also. And Rajesh also is traveling. That is the reason he is joining on iPhone and is quite a busy, nowadays with a lot of conferences. So
Sorry for that, sir.
no issue. No, sorry. No, sorry. Once you have joined, it's we appreciate this. So this doctor from Solapur, Parag, any reference for these guidelines and OT room? Nirmal, this is for you. References, I think Nirmal was giving in each of his slides. We will pass it on to you in case, Parag, you require that. Another thing is it legally valid? What are you asking about legally valid about? I don't know what is legally valid.
Need some clarity on that.
Guidelines, maybe the legal
guidelines references are, I think I already showed. This is a national building code is for the infrastructure.
Okay.
And what Dr. Namrata has also mentioned about the 4 zones and the administrative areas. So that is part of the Clinical Establishment Act now. So it has been regulated. Previously, it was part of only the accreditation standards. Now it is part of the Clinical Establishment Act. And
so it is legally valid.
Yes, legally valid.
So
and the third aspects are the guidelines issued by National Program of Control of Blindness. It is necessary for the CAM surgeries. If you are conducting large volume CAMs, it is necessary you follow the NPCB guidelines. And of course, AOS guidelines, since it's the largest professional association, it is also legally valid.
So, Parag, I think this answers a lot of your queries. In case there are, you can still write in the chat box. Doctor from J&K, Chatterjee, wants to know any chance of retinal toxicity when intracameral antibiotics are given? Namrata?
in case of PC tear, how much injected?
How much should be?
So I think as far as moxifloxacin is concerned, there have, to my knowledge, there have not been any cases reported. I think the Malika and Dr. Lalit sir can comment on that. But yes, with vancomycin, there were cases reported, and that is why, by and large, it was given up.
So I agree, Malika, Namrata, that aminoglycosides should not be used. That is very clear, especially in PCR, because macular infarction is reasonably common if you do that. And whereas this moxiflox, I do not think there is any toxicity. The usual dose can be given with moxiflox. There is no need to reduce the dose if there is a moxiflox there.
Yeah, so the point is that the dose which is allowed for intracameral use is also the dose that is allowed for intravitreal use. And hence, if we use within those, with that volume and dose, then there is no toxicity. But if you give an excessive amount of moxifloxacin or cefuroxime or any other drug, that would be toxic, of course.
Yeah, because like we were saying, that can induce TAS also.
Yes, yes.
That can induce TAS. But I am not aware of any retinal toxicity because of moxiflox.
No, because there's a dose which you have to give, which is less than 0.1 ml. Namrata, I may be wrong. I have not used it as a cataract surgeon. But I think you have to use a limited volume of the moxifloxacin, which is 0.1 ml, I guess. Yes. So that equates 400 micrograms of the drug, which is what is the permitted intravitreal dose. So you cannot automatically, you will not cause damage. But if you give 0.2 ml, then there is a risk of retinal toxicity.
Yeah. So any other question, or I think we should, yes, Rajesh, sorry, you can ask whatever you were wanting to ask. Rajesh, if you are there.
Actually, it's for everyone, not just for Dr. Namta or anyone. Basically, I was there at the Academy, American Academy, and a lot of discussion was going on that, a lot of surgeons are giving one-time injection of antibiotic and steroid in the vitreous cavity. And they are propagating no post-op regime for cataract surgery. Just wanted to have opinion of the experts regarding that.
Let's not propagate in this country at all. I know there are, this is not the first time this American Academy is doing this, propagation. This may be opinion of few people, but believe me, I remember Singapore, they used to inject a small pellet in the anterior chamber way back. And they said no post-op care required. If we utter these words in our country, no post-op care required, believe me, blunders can happen and a lot of legalities issues can come. So I do not think any of the panelists would agree that we inject inside and no post-op care is required.
I think
so, sir, I completely agree with you. Just wanted to have this message go loud and clear that in our country the scenario is different and we should not.
No, even if I'm in US, I will still not propagate this belief.
I think there is no evidence as of now in literature which supports this. So for anybody, I think it's something which should not be practiced.
Actually, you are entering the vitreous for no reason, first of all.
Yeah.
Now you have created one more problem, and a cataract surgeon is trained well, unless they are specifically trained for this. They are not trained to give intravitreals, and there will be that vitreous wick and many other problems which are being created.
Absolutely, I completely agree with you. The second point that I wanted to have a consensus on was we do prescribe preoperative antibiotic for there are recommendations for 1 day and for 3 days. So what is
Rajesh, that is the problem of coming late because this already has been discussed multiple times by the panel. And Namrata also hinted, in fact, I was wanting to ask her, because panel itself is divided, there's no clear cut, in fact, Nirmal said there's no validity at all. Namrata also I was wanting to ask pre-op antibiotics, although everybody, Rajesh gives, you also may be giving, but believe me, there's no literature to support that preoperative antibiotics definitely reduce the chance of endophthalmitis. Only thing which is available in literature as level 1 evidence is betadine. That's it. But preop antibiotics, Rajesh, you would agree that there is no consensus at all. And Namrata also, I want to ask, there's no legal this thing. There's no legal that in case Nirmal also stressed it. If Nirmal stressed that if it's a hospital policy, suppose I'm working center for sight, and there's a hospital policy which is there that you have to give, we may give. Otherwise, nobody can catch me by the neck that in case I have not given, and it's not legally binding at all. Namrata, the other question, Rajesh, you also, because both of you came from academy. AI's guidelines were quite, made waves there. And Namrata, you know that David Chang has taken up this, and you raised this point of blood sugar again, 200, because David Chang has questioned my guidelines because whatever we published in AIUS as well as guidelines of 200, and David Chang has questioned my this thing that why. Any reaction from Rajesh or Namrata?
Sir, I think he has questioned because the guidelines were there, now are on the PubMed. And these are the guidelines which, sir, had come so many years ago, and we are following this blood sugar level only. And again, like I said, there is no evidence to say for it or against it. And this is something which has been conventionally followed by all over the surgeons all over the world, all over the country. So this thing was that you should not say that, it is mandatory. I mean, you should say this is recommended. He feels recommended is a word which is not so strong, but when you say it is mandatory, it means recommended means that, it is recommended, you may or may not do it. But when you say
the reason, let me tell you the reason, Namrata, why they came into his guidelines was, I remember Dr. Grover was there and DC also was there at that time. And there's a lot of fight amongst us also, 25 people sitting, you were also there. And there is also a fight that why 200, because all the government data, government mein jitne bhi hai na protocol, they say 200, and that's the reason Lahane also was there, we included 200. And you see, all of us also agree that diabetics are a compromised this thing. And then third thing is, cat is not a hurried this thing that you can't control but sugar and get it done. So my points are, although it is not mandatory but definitely recommended, that you can control diabetes and then get it. I am sure there are literature evidence that may not be a level 1 kind of evidence that diabetes does predispose to more chance of infection. There's no doubt about that. No, Namrata, Nirmal?
Absolutely, and in fact, the US cannot be compared with India in terms of post-operative hygiene of the patients. So we do need to have more stringent guidelines. We cannot just say that you can operate at 300.
So one question to you, Namrata, you showed a very good photograph of a lot of scrubbing being done for a couple of minutes, and then you wear gloves also. So there's no hand contact. Ultimately, it is a glove which is touching. So why do you want to vigorously scrub so much once you're wearing? Because the era when gloves were not there, when we were junior resident RP center, there were no gloves at that time. At that time, we used to have brush also and all these things. But now, in the era of betadine scrubs, why so much of vigorous, rubbing? Because you have to wear gloves also after that. And gloves are supposed to be sterile.
Sir, that is a standard protocol.
Standard नहीं, वो तो अंदर रह गया ना, वो वहीं से वो तो हाथ तो अंदर रह गया, तो gloves आप ऊपर से पहन लिए.
Yeah, no, but still, I think this is what is classically taught. And
why do you think? That is the reason I'm asking. Why do you think so? Nirmal?
The gloves may not be completely safe. There may be a hole or something. Micro.
No, Namrata, no. That means you are saying that glove के deficiency के लिए हम scrub कर रहे हैं.
No. Can I answer this?
Yes.
Yeah. So the methods of hand hygiene was a lot of simulation exercises were done, and during the various types of hand hygiene measures, they found that the web spaces and the back of the the hands were not properly disinfected with the usage of 1 or 2 ways of cleaning. So that is the reason the 7-step hand hygiene method came, and it was accepted by the CDC as part of the guidelines for hand hygiene. So one. Second thing is the usage of additional personal protective equipment. It is not only from the infection point of view, it is an added barrier between our hands, particularly when surgeons have a lot of hairs. So there is shedding of the surface flags and the hair follicles, and this is supposed to carry a lot of bugs. So to prevent that, we need additional barrier. That is the reason why they advocate personal protective equipments, and gloves have been proved to be the best recommendation. It has been validated, and as per the norms, it has validation from many retrospective as well as prospective studies. So glove as a PPE is a validated protective mechanism.
And Namrata, what is the protocol in RP center about intracameral? Do all of you give or not?
No, again, it's a divided house, and some people like to give in all cases, others only give in complicated cases.
Rajesh, do you give or not?
So I like to give only in complicated cases. I do not give in all cases.
Complicated is PCR. Apart from PCR, what else?
I think only PCR.
Only PCR. So PCR you hardly encounter. That is the issue.
Yeah.
Rajesh?
Can I add
Rajesh?
a point here? There's one thing called as risk assessment. So whenever
Sir, actually, there was some network issue. What's the question, sir?
Question was your take on intracameral antibiotic. Do you give or not?
Sir, actually, till last
As a routine,
couple of
as a routine, Rajesh, you give or not?
as a routine now I'm giving it because of basically some litigation issue, and I mean that's the only reason why I feel, because for the last till 2 years back I was not giving at all in any case, and I never had any problem. But because of so many literature now supporting intracameral antibiotics, and there can be some issue related to that. I mean, that's what I say even in CME, is that to save yourself from litigation, I guess intracameral antibiotics should be given. How much safe?
You give it because of fear.
Yeah, and plus whatever extra safety it provides.
Yes,
But the fact,
Nirmal, what do you say about risk assessment?
Yeah. So whenever we have a doubt, we need to do a patient profiling and risk assessment for that particular patients. So if the patient, so it may be general risk like diabetes or some immunosuppression or dialysis, patients on dialysis or any other drugs. Second, the ocular risk like intraoperative complications or any other risk of infections, we are justified in giving to that particular patient. So we have to include this as part of the surgical assessment. What are the risks for the for giving antibiotics intracameral?
sir, just one point I would like to add here, sir, that nearly 60 to 70% of people in this country are not giving intracameral antibiotics.
Yeah. So I agree with you. What I think Nirmal said about the, each patient has to be profiled and risk assessment has to be done. And I reiterate the fact that nobody is going to catch you by neck or legally that you have not given and then you have admitted. But I think from the patient point of view, risk assessment agar kar le, so it is worthwhile giving in complicated patients what Namrata was also saying. So a couple of more questions before we ask DC to give his very important talk. These are all for Nirmal about OT rooms, sir. Tiles. What material should you prefer, tiles or any other material?
Okay, any material that is hard enough without any moisture and easy to clean. So you can use
Can we specify
large
that?
tiles. You can use large tiles 2x3 or 3x3. You can use marbenite. You can use hard granite. So when you are selecting hard granite, you have to be very choosy because some of the granites can have moisture. So these are the three things. And the fourth, now it is PVC material, which is now freely available. And fifth is stainless steel, medical grade stainless steel.
Okay, I think Parag, this does answer your question. Then is HEPA filter a must? I am sure that you will come to that, NABH and other things. So what is your, because since this question is being asked, that is the reason why we are here.
Okay, yeah. So HEPA filter, if you want highest protection and want to go for accreditation, yes, it is needed to have a proper guidelines to follow proper implementation of the guidelines. So otherwise, we are scope of services limited to anterior segment surgeries and minimal number of surgeries, and only entry level, you may not need it.
So not a must for entry level.
Yes, not mandatory, but it is recommended.
Recommended, not mandatory. So one question from Tamil Nadu is a big question. Let me read. Can we have policy decision regarding the poor irritating fluids which are bought by the government for public? Can we have a registry which prompts ophthalmologists to avoid certain companies So these questions are more for Honorary Secretary and Honorary Treasurer. I think if you look into it, can't be answered in one go. But I agree, Zebu Sia from Tamil Nadu.
Zaibunitha.
Yeah, yeah.
Yep.
So I agree that this is because sometimes for no fault of surgeon and for only for the poor quality irrigating solution available by the pharma companies, surgeon has a legal case. But I agree with you that whenever there is a case, these companies also should be taken to task. That is very, very important. And can we have a registry which prompts ophthalmologists to avoid certain companies irrigating fluids? Theoretically, yes. Practically, I don't know how much it is feasible. But whenever somebody complains to us that from this company he has used and there was a cluster, I think DC will elaborate on this. So we do take into account and we do a case finding, inquiry and sometimes visit that place also and temporarily warn all the members of the. And in fact, we at AIS level do this thing whenever we find out that like Avastin this batch is causing or irrigating fluid this batch is causing, we do raise an alarm. And in fact, VRSI also does that. So that is a very good.
One problem is we cannot pull up the company because we had this problem in Hyderabad in the government hospital, and the company just says that this was never meant for ophthalmic use. Why did you use it? So unless we are using BSS or something, we cannot pull up the company legally.
Yeah. So there's one. Just want to add a point. Now government has come out with a national medical device policy. So where the registration and all those things are mandatory, and it also added all the consumables and fluids as part of the Drug and Cosmetic Act. So there is more stringent rules for the companies. So that is the regulatory requirement. As for the AAOS, we can issue advisory about restricted usage till the issue is solved about that particular batch. I think that VRSI and AOS have already been doing. The policy decision is, I think AOS can't take it at our level because it has to be taken at the ministry level.
So one thing I always tell is that please do not go for cheaper versions of whatsoever. Suppose Ringal Lactate is available for 25 rupees, then you get for 14 rupees, you go for that. So don't do cost cutting because it's likely that there is a compromise. The Parag is still continuing with his question. He's asking, tiles on the wall is sufficient or steel walls are mandatory?
No, steel wall is not mandatory. Tile wall is okay if your people are able to clean the crevices properly and there is no moisture.
And HEPA filter, I think Nirmal has already stressed. I think Parag, you must have heard about that. So with this, I think let's move on to another very important talk for which we asked Dr. DC from Coimbatore to be here. Namrata, it will be good in case you can be here or in case you want to go.
Yes, yes, sir. Yes.
So this is on cluster endophthalmitis because this keeps cropping up sometimes. And what should the ophthalmologist do at that time? Was a situation of panic. Sometimes, I know there are red alerts, green alert, yellow alert. So many things have been said. And what actually is cluster, I think DC will definitely tell us. But I would like him to pinpoint things which the ophthalmologist should do apart from, doing all these inquiries and, logbooks and what sterilization methods, review all those methods. What should you do? Because he should write to AIU's legal cell. He should not respond to, lot of, press media and other things. So that is more relevant. So let's hear DC. Yes, Chandrasekhar.
Warm greetings to all of you. To the panels, expert panels here. It is an honor to be part of this panel and all the people online and who will be seeing this later. So there are some examples which I'll be quoting, some images, everything will be there, nothing against anybody or any hospital in particular. The doctor was a god model for a few decades back, but now the healthcare has shifted towards patient-centered approach. So imagine even for a small complication, even for a person who gets 6 with glare, he can sue us in court and go for a case. But imagine if it is an infection, it is going to be a huge problem. And if it is going to be a cluster end off, it is not going to be easy at all. And because of the access to knowledge of various diseases, people, even camp patients know what to do. Even if they don't know, there is a lawyer who will come and tell them all this and tell them, I will get you 10 lakhs of rupees. So it's a nightmare of nightmares to face a cluster infection? This is by definition, any surgical site infection within 30 days is called a surgical site infection. But if there is an implant in wherever the organ which you are operating, it can go up to 90 days. And what is a cluster? There are usually they say 5 cases on a single day or consecutive days. But if you ask me, even 2 cases on a single day in the same table, think it is going to be a cluster. You have to work up like how it is going to be a cluster. There are many clusters happening in India, take it from me, but not all of them come to limelight. Not all of them are reported. So basically, the publications are very minimal. So nobody dares to tell that I had a cluster, and that is why some of the problems occur. But we have, as Dr. Namrata said, our improved protocols, antibiotic coverage, early vitrectomy, and all those things have made it much better today. And we have the kind of infrastructure and expertise to manage endophthalmitis, and we can treat them to get some kind of good vision. So these are studies which have been already quoted, and intracameral antibiotics, to our knowledge, huge amount of studies have come for huge amount of people, and it will stay good in the court of law if you say that you have given intracameral antibiotics at the end of surgery. So where do they occur? It can occur in a small OT where there's only one table to a regional institute or which is part of a multi-speciality hospital. Where could be the source? Just about anything. If you see, everything in the theater is there, including povidone iodine. The povidone iodine itself, we have isolated pseudomonas from unopened bottles of povidone iodine. The IV tubing, which are shared, sometimes they have this kind of infection. Just about anything. And the last one you see, there have been some instances where the assisting nurse had a subclinical infection, and that has landed in a cluster. It is a very subclinical infection, but there was a microbiologist who took the swab and took this endophthalmitis and sent it at those days, sent it for Italy for genetic matching, and it happened to be the same organism. So the problem could be in the OT infrastructure, it could be in the sterilization, it could be with any of the devices or medicine, personnel. The patient, one patient who's infected can make it also a cluster, unless our in-between cleaning process is good. And from water and environment around the hospital also matters a lot. So this cluster, what is it now? The most important is when a cluster occurs, there is always an internal conflict, be it a small hospital where one surgeon or two surgeons are there, even in a big organization. There is a panic. But the bigger organizations are better equipped, just like how we have code red for fire, code pink for whatever, all these codes. Today, we even think of, what we should be doing if there is a cluster. There should be a protocol. Today, the infection control manual should have guidelines for management of cluster infection. So there is no point panicking. If we are not sure that we can manage it boldly, better to take a help or straight away call expertise or refer. So there's no point even telling that there is no problem. I have been operating for 10 years without endo. I don't know how this has happened. It can happen. So immediately we have to find out what is the source and eliminate. That is primary. Then you do not want further catastrophes in your further theaters. You have to manage the already infected patient, and you have to be ready for a proper governmental agency investigation once it goes public. Another important thing is identification, investigation, everything is done. It is mandatory. You need not say it is only for camp cases. Any cluster, we have to report to the District Blindness Control Society. It is our duty to do that. And of course, when it becomes a cluster, it all depends on how we manage. And managing these attenders is not going to be easy at all. More than the patient, these attenders can give us a lot of challenges to face. Then again, look at the infrastructure point by point. So many things have been told by Nirmal and everybody else. So we need documentation. If you have not documented, it is as good as not done. If your protocols, whether it is being followed. Sterilization, if you look at it retrogradely, 2 days back, one validator would have failed, one indicator would have failed. So that would have been neglected by the staff who's a junior. So that would have been the beginning. If we had looked into it, we might not even land in a cluster like this. And important, very important to find out, see, cluster endophthalmitis has to be only iatrogenic. At least independent endoph can be sporadic, or it could be from the HAI. But the cluster will be 100% from the hospital only. So look at the case sheet, the documentation in the case sheet, signature, pre, what all you have done, post, dated, signed, dated, timed. Informed consent in India, more than 50% of the cases are lost in the legal battle because of improper. They have the consent, but it's improper. It doesn't have all the requirements. Keep everything, investigation, scans, photos if possible. Then minimum 3 times is ideal. If you ask me, morning, afternoon, night, before you go, you have to make sure how the case is, how he's responding, and also you have to comfort the patients, all these patients. Sometimes we retain them, they all form a group together, and within 1 or 2 days, they all start talking against the hospital, and many things happen. And if you do not have a retina person, you do not have this expertise, call them, then you decide whether to refer to a tertiary center if it's a small hospital. It is nothing wrong at all to refer. These consent forms will go a long way. It should have been understood by the patient, not like, ideal to shut down the OT, workup. The environment should be looked into. Unless everything is fine, better not to proceed with the other surgeries. Review your protocols, validations, all the validations. There are now recommendations for validations which are mandatory, where each surgeon should have seen the indicator change in the set he is operating on. Not only the line sticker, they will class 5, which will tell whether the pressure, the temperature, time, everything has been good. Do a thorough workup. Look at the medicines. The medicines, sometimes it has become mandatory to take at least one sample medicine in each batch to check before it is being put into use in the theater. So when these things can become legal is the important question. It may not become legal. There have been many clusters, they don't become illegal. The hospitals tackle them well, they get them good vision, or they tackle them with compensation. But suddenly one day morning, without your knowledge, they may go and block the road, or they may tell a news reporter and it will be there. And you will get the phone call and say, it is all over the place, I see your name. So it is not an easy one. It has to be mind should be prepared. Mind should be prepared to tackle how. Important to tackle attenders and public, where all attenders, one patient, there will be 5 attenders coming and they will all be demanding money, which we can't even imagine. Patient may not ask anything. You have to tackle the media. There should be one person who will really give the actuals without telling too many things. You have to face it and face the investigation. Take the help of AOS, State Association, IMA, they can help. But once it goes into the governmental investigation, only what you have been doing, and if they are against standard protocols, then it will give us a validity in the court of law. If we have not followed any standard protocols, it becomes. Usually the investigating team would be a joint director or a dean, one government surgeon, ophthalmic surgeon, and a microbiologist. So all these people will come, and they will be a team from District Blindness Control Society or state, the drug inspector, the police will come, and the human rights, state human rights, and various human rights followed. There is one instance where the human rights took up the case from a local court to the CBI, and it went on for years because they gave a wrong statement without understanding what they told was not actually true. It got blown up to out of proportion, and the people involved actually faced a lot of things. So in the court, we need to prove that basically one thing is, when they come, they will have a standard checklist. That standard checklist, it will go into all aspects of prospective and retrospective. Example is, how many gloves were consumed in the last 1 year, to see if you are using one glove for each patient. What is the medicine? Whether you're sharing some medicines which cannot be shared. Today we have a protocol that you can share consumables, but it should be proper in between what we have done. So the retrospective aspect will give a lot of clues to them where we cannot hide. We can say this is done, this is what we do, everything. But the retrospectively, if they look into the consumable, some of the things they will prove we are wrong. These licenses, as Dr. Nirmal opened up and said, all statutory licenses should be in place. Even if you have done 100% right, and we do not have a statutory license like Clinical Establishment Act, Pollution Control Board, then the whole thing will go against us. They will check the environment, sterilization, various validations, consumables, personnel also. For example, in one of the biggest clusters, 69 people were called to the state headquarters by CBI, and all of them were questioned independently. For example, the person who handles the autoclave will have to give, what is it? What will you look for? Something goes wrong, what will you do? When will you know? How will you do this servicing? So many questions to just to find out the processes in place. This is what is important. The sequential documented evidences of what you have done for the patient once cluster has occurred is important. Case record should be complete, and whatever, whether it's electronic medical record or this thing, these are registers that should be, will give us a lot of value in the court of law. It should be sequential. I can't create something for only 1 week or 1 month. It should be for years running properly. The logbooks, how the theater logbook, autoclave, flash autoclave, everything is important to show that you are following. Surveillance register. Sometimes the surveillance, the count would have been high, which would have been neglected by the OT staff, where it was done in a separate lab. That will go against us. If unwanted counts of unnecessary organisms, then it becomes a problem. People should be knowing, not the CMO, not the infection control doctor or nurse. The people who do should know what they are doing, and they should be able to say what happens when something goes wrong, when they will stop the theater and warn the team, we should not go ahead. Camps, especially, everything goes, there should be a permission from the DBCS. The camp organizers will also be questioned. Patient details, now it has become so, it is all done online, everything is captured, not like those years. So this is what is important. How is the hospital affected? It will be closed. Some of the hospitals will be closed for a very long time. Employees become jobless, and comeback is very rough from these extremely dangerous situations where it goes public. Sometimes the surgeons are threatened and sometimes assaulted too. The co-professionals are most important. They have to give the moral support. Sometimes we have seen our own colleagues talking negatively. This will happen if they do like that. They don't use it. They do not have a protocol, which is absolutely not correct at all. Then, of course, the family support and the other patients, we need to know how to tackle them. These are some of the ways they can register a case. Wrong surgery performed, cause of loss of one organ, forcefully retained a patient. All this they'll go and register. These are all governed by the lawyer. In case it's a free patient or a poor patient, give them some money and say, you sign, I will put a case, end of the case, we'll get 10 lakhs. Sometimes this is also happening in some of the places. There is a Supreme Court order that we should all remember, that no surgeon can be arrested. There is protection from the Supreme Court. This is only a case of medical negligence or not. What we need to prove, it is not, that's all. And what those fellows will try to prove, it is medical negligence. It is not a criminal act where I have hit a person, cut a person on his hand, just because I'm angry. This is a medical negligence. Unless proven by a group of experts in the same field, then only they can arrest. Otherwise, nobody can arrest a doctor for this kind of medical, unless it is proved. That is the main thing. Independent and competent opinion of a doctor or qualified in the same branch is necessary. This is a Supreme Court judgment. There is no need to fear this. But if we have all the protocols in place, documentation in place, we have followed, we will come out. But there will be some amount of compensation that will be awarded, because even if it is one patient, it is his height. So this is like Dr. Lalit Stat was one of the first to start these efforts after a major cluster. 3 clusters were there at that time, and it was a very fruitful thing, though at that time some of them were basic, which will not be accepted now. It has got revised again and again, and I'm happy the AO's expertise, Amrita Madam, Lalit sir, and everybody are constantly trying to show this. As Dr. Lalit sir said, there is no need to think that we are talking about the same thing. Even if you have to listen to it 3 times a year, it will go become a practical code, drill in your mind, and you will know what to do. We offer really high standards. We give them 6-5 vision, everything. But somewhere, some people, it can be, need not be the doctor. Somewhere down the line, a junior person who's handling a CSSD, an assisting nurse, which touches something which is unsterile, then the whole catastrophe may occur to the patient, and it can become a cluster. So if it is not documented, that means it is not done. If it is not recorded, it has not been done. So no way of telling that we have done, but we forgot to write. So this is also equally important, that we work. But unless we review what we are working, we see the validations, there should be some important person, a doctor or infection control person, to take care. Our dream is to have a 0% incidence of postoperative endophthalmitis. Whether it is going to be possible, whether it's a dream or reality still, but we have come down to 1 or 2 per 10,000, which is absolutely good, and they are sporadic. but dream is to really not to have any clusters at all. It is really important. Cluster endophthalmitis, once somebody gets cluster, it doesn't mean they are immune. You should be more careful, all the more careful not to get another incident. So there's no point in breaking our head and saying that failure has occurred, I will not operate, nothing like that. Failures do not actually define, there are many factors, but it should drive us to become more perfect, get everything in place, and see that we have a good outcome and we prevent cluster. Thank you so much for your patient hearing. Thank you, sir.
Thank you, DC, for your bombastic and scary talk. Actually, you scared everyone, whether we should be operate or not. I think the first talk and this last talk are two important things which all ophthalmologists, I'll request Sipla and Pooja and Nitish and whoever is listening to please make available these two talks, one by Nirmal, one by DC, apart from what Namta said, Malika said, and Rajesh said. So I thought I will forego my talk because that is the least relevant talk for this purpose. And what is more important is how to follow protocols. And I'm very much fancied by this statement what was made that documentation is only thing which will save you in court of law. Other thing is preferably have a lawyer friend also, because you see these people instigate patients and their relatives and families. Arey case karo, which both of them both become parties to all these things, which is bad. But only thing which, believe me, the judges are not fools, but they're not scientific people also, because they don't understand. You can be make a scapegoat also, even if you have not done a blunder. So therefore, documentation is what is going to save you, and sequence whatever. You see, negligence is not the same thing as poor result. You see, if you have done an intravitreal, then the eye is lost. Judge is not going to catch you. If you have done a vitrectomy, eye goes to phthisis, does not matter. But if you're not done intravitreal and then something happens, I know a patient. I will not name he works for Times of India. He was referred to me. Intravitreal was given, recovered 6-9 vision. Still, he filed a case against the surgeon. You see, good result also because the previous surgeon had not given the intravitreal. So what I'm trying to say is that documentation is very important. Treatment protocols have to be followed, but do not think that just because there is no result does not mean it can be negligence. Until the time what DC said, Supreme Court, that ruling is there, has to be examined by a body of same specialty, experts before. So police may come. Don't be afraid. Police can't arrest you. Police can't arrest you on this. That just because the relatives are shouting because there's an infection or there's PL negative or whatever. So let's see. There was a couple of questions here. Gurmeet Singh said, "Can we save the webinar?" Yes, Gurmeet. We are making efforts to make this webinar popular amongst all the people. So yes, Malika.
One of the most important things in managing a cluster is having good rapport with the attendants. If you have, that is the single biggest protection actually. If you're a patient and you show a lot of empathy, you should feel empathy, of course. And a lot of time has to be spent with each patient. If you are in a hurry again with other work, if you show how committed you are doing vitrectomies every day, you're doing IOAB as required, then that is your biggest protection.
Absolutely. 100% I agree with you, Malika, because you have to empathize with the patient, and the patient should feel that you are with him in this disaster and you are working day and night to try to save his eye. Then, legal case may not happen.
Yes.
But if you, use loose language,
yes,
and the infection ho gaya or aankh chali gayi or whatever, then is the issue that, patients take to court of law. Always talk, and talk, because I have one slide where I've written talk, and talk. You have to keep talking to these people, then only they will, listen to you. And believe me, a lot of times we save these eyes. We save these eyes because you have talked to them and they are, they become compliant to your treatment. Because it's a moment of, sad this thing for them that they have not got the result. So talk to the patient, talk to the patient. So any other point anybody wants to make?
So you can have your talk quickly without any discussion on that.
No, I don't think so because management of endophthalmitis. Let me show you one or two slides only. I will not, go with the entire.
Practical.
Yeah, yeah. This is one slide which I, wanted to re-emphasize. This talk I already said. So these mayas have already been discussed. In fact, he said betadine also Pseudomonas has been highlighted. So where do we go from here now? Betadine also is not reliable. The studies have been quoted. And this is the only slide which I wanted to show. Intravitreal antibiotics, Mallika stress also said that if there is a gray zone, err on the side of infection. And you will never regret in case you have given intravitreal antibiotic. Because believe me, I put that in red. If injected early and if organism sensitive, believe me, results are very, very good. And if not, in case you are not doing vitreous surgery, you cannot do vitreous surgery, please refer this patient. Because referring is also very, very important, aspect of this. And the other thing, I just will skip a couple of these slides because a lot of these have been covered. I don't want to show any videos here because aim should be on prophylaxis rather than treatment. Treatment is primarily between antibiotics, intravitreal, follow up closely, and do early vitrectomy. Nowadays, with MIVS, believe me, results have improved and surgery has been relatively simpler. And results can be better. This is what I also wanted to show was do not panic, as I already said, but easier said than done, DC. Panic to hota hai. Panic to everybody happens. And one person should talk to the media, have a scientific dialogue. What I tell is, patient ko, whenever there is a cut, there is a chance of, infection happening. And review various factors, but document, have a peer review. This is also what Mallika was stressing. Empathize with him, summarize your next manufacturing, take a peer review, ensure privacy. The patient should not, in front of everybody, start making noise. So they are very, very important things which have already been stressed. So therefore, I said I will not show in the entire management part of it, but two things I have stressed is early antibiotic injection and early referral for vitrectomy and document. So with these very nice presentations, because believe me, time is not on our side, I will thank all the speakers, starting from Nirmal, DC, Mallika. In fact, Namrata also joined and Rajesh also joined. I'm thankful to all of you for making this webinar very, very lively. And I'll request, Pooja, are you there? Or
Yes, sir.
I thought you were having dinner.
So, no, sir.
No. If Nikesh is also there, I would like him to also join. Because you people have done a very good job for ophthalmologists, and believe me, not only help provided to AIUS when we wanted to publish these guidelines way back when I was secretary more than 12 years back. That was the first time DC had come and we had these guidelines, and we have coming out again and again. And as I said, these guidelines need to be hammered again and again, and those charts need to be redistributed, and also this very important talk by DC. What should an ophthalmologist do? In fact, you see, although these talks have been Googled, but if we can collect a concise document small, it will be very useful and very important for a budding novice who starts his practice and who is not a big name. The guidelines given by Nirmal is, very. You saw 90% of the questions are addressed to Nirmal only.
Yes.
Tile use karna hai, kya karna. So this you have to help us in, framing all this, focus group kind of guidelines where we again get together and distribute these guidelines.
Yes, sir. We are definitely there for all these scientific activities, and definitely we require your help and help of AIS also. And it has constantly been with your support that we have been able to do this. So thank you very much, sir. And thank you, AIS also, since collaborating with us since so long for all these scientific activities, sir.
So thank you very much, all these speakers.
Thank you.
And
thank you, President. Very well moderated and a lot of take-home points, and also the wonderful decision making on the importance of this topic.
Thanks a lot.
Thank you, sir.
Thank you so much, sir. On behalf of CIPLA, I would like to thank On behalf of CIPLA also, I would like to thank all our distinguished faculty for taking out their time and making this event a grand success. Just for everyone's information, we had more than 250 attendees for this webinar. And I would also like to thank all the audience who took their valuable time and attended this webinar. And we assure you we'll plan many more such activities and webinars as well as physical meetings in future too. Thank you so much, everyone.
And I will, take this link from them and put it on the website and try to
Yes, sir.
publicize this so that people who have not heard, they should
Yes.
hear these talks by great people. Thanks
Yes,
a lot.
sir. Thank you so much.
Thank you so much, sir.
Thank you,
Nirmal.
everyone.
Thank you, madam.
Thank you so much.
Thank you.
Thank you, Sipla.
Thank you.
Okay, have a nice weekend.